So we're going to have another alumni lecture. This is Dr. Angela Kai. She is a clinical assistant professor at the University of Pennsylvania, majored in physics at Duke, where I'm told she tended for the Duke basketball team. After medical school, after she went to medical and business school at UNC Chapel Hill, she completed her residency here at Kings County in 2021. Following residency, Angela did an innovation fellowship at U.S. Acute Care Solutions. During her fellowship, she lived in D.C. and practiced clinically at a community ED in Hagerstown, Maryland. Angela is active in specialty advocacy. Ooh, sorry, I'm not reading this very well. Angela is active in specialty advocacy, finishing her 5th year on the EMRA Board of Directors as immediate past president and a current PACEP Leadership Fellow. Her academic interests include emergency medicine business models and alternative payment models that facilitate taking care of patients outside of the hospital. So give it up for Dr. Kai. Hi, can you guys hear me if I stand over here? Okay, awesome. That's on. Okay, well, anyway. So it's great to see you all. Unfortunately, I only recognize 25% of you, but hi. So this was actually built off of my senior lecture. So whenever you guys get to a senior lecture, remember that it can kind of be a launching point for whatever your future interests are and take it around on tours. This is a talk that I developed based off of my experience working in specialty advocacy on the EMRA board. I think there's a lot of misconceptions or lack of information around business models in emergency medicine, whether it's contract management groups or other different employment models. And I think it's something that you guys probably don't get a lot of exposure to in residency since you only work at certain types of health systems. We tend to train in academic environments which don't necessarily reflect the entire community of how emergency medicine practices are managed in the country. So while I was on the EMRA board, I had the privilege of meeting all different leaders from across the country, from all different size groups, from independent, small, all the way to the largest groups in the country. And this is kind of what I've learned from that. Just some disclosures in the sense of just knowing the types of places that I've worked for. Obviously, I worked here. And then I worked at U.S. Acute Care Solutions for a year, which is a contract management group, like a national staffing group, which I'll talk to you guys more about. And it was basically like an administrative fellowship, and I worked in the community at the same time. So USACS is about 90% physician owned, and then there's about 10% of the ownership that's by hospital systems. They used to be 1/3 owned by private equity, and then they sold off those shares with a loan from a different private equity company. And currently I work for University of Pennsylvania, which is kind of a model you guys are probably more familiar with in terms of being a large academic private health system. So these are all my own opinions. They don't reflect any of the places I work for or EMRA, but hopefully it's a very informed opinion, and I hope that it can be useful as you guys go into the job market and try to figure out what you want to do. So just want to do a quick exercise. If you guys can just shout out some things that when you think about where you want to work in the future, what are some of the things that you care about? Location, that's number one, probably for a lot of people. People you work with, something back there. Salary, yep. Type of employer, which is kind of what we're going to talk about. What was that? Staffing, yes. What is how many patients per hour you're expected to see, what kind of coverage you have, whether you have single coverage. So this is kind of capturing a lot of the things you're probably thinking about. So in terms of how we think about whether we're going to be satisfied with our future career, which is really what I think we all want. This was a useful survey that was done of physicians and satisfaction, and it kind of laid out different themes that people talked about and that contributed to their satisfaction. So your autonomy and being able to make your own medical decisions, compensation, what kind of resources you have, specialists, people to help you do out of title work, like carry yours around, how much personal time you have, the administration, and down the list. What I would argue is that about half of these can be affected by the business model that you work in. And that's kind of what we're going to talk about. So what do I mean by the business of running an emergency department? If you were to go to a hospital and say, I want to provide the physicians for your hospital, you need a lot of cash to start a group. Because when you see a patient, it takes you, 2 days to finish your notes, and then it goes to a coding company, and that takes a couple of weeks for them to code the chart to say, okay, this is like a level 4 chart, and then that has to go to the insurance company, and the insurance company denies or downcodes your claim, and then the hospital has to resend the claim back. So you saw the patient on April 1st, and you might not actually get cash for 2 months, but you still need to pay all the physicians on your payroll. So you need a lot of cash. You have HR, you have to manage the benefits for all of your physicians. If there are problems like misconduct, you have to manage that. You need to manage your legal contract between your group and the physicians, and then your group and the hospital, and also any contracts you might have with insurance companies. That's what I mean by payers. And then there's the billing and coding process. You have to determine the compensation for all of your doctors. And then you just have to do the day-to-day administrative stuff in terms of scheduling, quality improvement, malpractice, which is about 20% of your salary, that needs to be covered somehow. And then you also have to decide how you're going to govern yourself as a group. Are you just going to have a medical director who makes most of your decisions? Are you going to be a partnership group where everybody is a part owner, and therefore you kind of have to vote on all of your decisions? Those are the kinds of things that it takes to run an emergency department. What I want to introduce to you all is a framework for the different types of practice models and terms that kind of get thrown around. So we're kind of just going to roughly cut the EM job market into different business models. It's a little bit imperfect, but it kind of explains some of the terms that you've probably heard, and it's just kind of a starting point. So on one extreme, you could have a sole proprietorship. This works better for outpatient medicine. You could be a single doc, or you could, create a business under your own name and then hire other people. But from a business perspective, it's your group, you take all the ownership and liability, you get to make the decisions. This doesn't really work in emergency medicine because we're such a resource-intensive specialty. We're a hospital-based specialty. So it's kind of hard to just have a business under your name alone. But just for the sake of illustration, you can think about that in one extreme. Another term that's often used is a democratic group or an independent group. Those are similar and overlapping terms, but every independent group is not necessarily a democratic group, and every democratic group is not necessarily truly democratic. You could have, what this usually refers to is a bunch of docs come together. They usually have less than 100 physicians and maybe see a total of under 250,000 patients a year, maybe at a couple of ED, one ED or a 2 ED. And usually there will be some type of partnership track. So you either have to put in money or sweat equity to become an owner of that business. And therefore you have to participate in the decision-making and all of that business stuff I talked about. You have to participate in that and take some personal liability for what happens to the practice. You could also work for an independent or democratic group as a quote unquote employee, where you're not necessarily an owner, but you're employed by that group. And I should say, if anybody wants to ask questions at any time, please feel free to jump in. And what I mean by every democratic group is not necessarily a true democracy. You could have, partnership tracks, but you could also be working for a dictator who doesn't necessarily share all of the decisions. So whenever you're looking for a job at a group that says that they're independent or democratic, there's some questions you should ask about in terms of how the hierarchy and structure and governance of that group actually works. And what is the expectation for your vesting period in terms of, usually if you join at the beginning, they'll give you more shifts, night shifts, and over time you kind of get better schedules. And then after a certain amount of time, you might have to put in some money in order to buy into the practice. So the next group is called Physician Practice Management Group, which I use this term instead of CMG or Contract Management Group, just because for academic purposes, I think CMG has become kind of like a pejorative term in emergency medicine, so it kind of precludes us from having like intelligent discussion about it. But have you guys heard of the term CMG? Yes. Okay. So the reason I call it Physician Practice Management Group for this purpose is because it's actually a very common business model in multiple specialties. The reason it exists in emergency medicine is back in the 50s, when emergency medicine was a young specialty, emergency departments, probably all know, were not necessarily staffed by board certified emergency physicians. They weren't necessarily staffed 24 hours a day. So it's actually quite amazing what we do now. So it was really hard to staff 24 hours a day. So doctors and hospitals had a hard time doing that. So they started hiring other people to find people to work in the emergency department. And so these docs would come together and just figure out like the recruitment and the contract with these doctors. And that's sort of like the beginning of how contract management groups started. They've kind of ballooned over time for a few reasons. One is that hospitals do hospital billing, which is inpatient billing, whereas emergency medicine services are billed on an outpatient basis, and it's a little bit different how that works. And hospitals are not always that good at doing that process, so they might be under collecting revenue. The contract management groups over time got really good at figuring out emergency department billing, and that helps them, generate more revenue and become more profitable and also grow. One of the big impetuses for growth in emergency or in healthcare in general, like why hospitals are consolidating, why physicians are consolidating, is in order to have higher leverage against insurance companies. So there are basically like 4 large insurers that control most of the private market in the United States. So if you're one group staffing like emergency department A, and you're coming to Blue Cross and saying, hey, can you pay me this much? The insurance company has a lot of leverage to say, no, we don't accept your rate. But if you're a group and you have 100 hospitals, or if you're like a big academic medical center, you have a lot of leverage. So that's why there's a lot of momentum to consolidate within the physician space and hospitals. Theoretically, there's also like economies of scale. Instead of having one person trying to, recruit 15 physicians, you can have one person trying to recruit 100 physicians. So theoretically, there are some economies of scale. There's like mixed evidence about whether or not large groups really do provide that. And certainly you lose some of your individual power as a physician when you join a larger group. Any questions about that? So hospital employee, I won't say much about this. This is probably one that you're all familiar with, since you all are essentially hospital employees. In this model, you have no ownership of your practice, and your management, is not necessarily democratic. And so your experience can really vary depending on what kind of relationship your department chair has with the hospital in general, and how much effort your medical director or your chair takes in getting your input into how you want the schedule to be built, how much coverage you want at different times, how the flow works through the department. So there's a ton of variability in that. Compare that to the other extreme where you have a truly flat democratic organization, all of those decisions can be made in a shared way. Whereas if you're in an employed model, there's a lot of variability in how that can happen. Some of the benefits, about half of physicians are employed as direct hospital employees. And some advantage of this are people are familiar with it. They provide all of your benefits and kind of take care of everything. And some people find it to be more stable. So the last model I'll talk about is sort of an umbrella term for corporate model. And what that may refer to is that your practice is owned by an investor. It could be publicly traded, which there aren't really any EM groups that are publicly traded right now. Envision and Health used to be publicly traded, but now they're private. It could be private equity owned, and that ownership could be a minority stake, which is pretty uncommon. Or it could be like a majority stake or 100% ownership. And then another, sometimes people, when they say corporate, they also refer to quote unquote for profit. So just to delve a little bit into like, what does it mean to be for profit? So a nonprofit is really just a tax status. There's some history behind this in, you know, how this was developed. The IRS wanted to give, you know, good hospitals that had sort of like a public mission credit for all the work that they do. So the tax status was created. In the beginning, it was very more objective what it meant to be a nonprofit in terms of basically charity care. But over time, that definition has become a little bit amorphous. It's not necessarily the dollar amount of free credit you give. There's other sort of immeasurable things like research or teaching that kind of go into that formula. So it's a little bit harder to measure in dollar terms. So the reason this is interesting is, you know, a lot of these nonprofit hospitals and health systems, they get a tremendous amount of benefit by not having to pay taxes. But a nonprofit hospital doesn't mean that you don't make any profit. You know, these are some of the most, you know, high revenue generating systems, some of whom have very good names, but, you know, they all make a lot of money because every business in healthcare, including hospitals and practice groups, are all for profit. There's a little bit more being studied about whether or not these nonprofit hospitals are actually giving back the same amount that they get in tax benefit. There's this one study that kind of, by their methodology, they felt like their tax exemption in a third of cases exceeded the amount of community benefit. This is a little bit hard to measure, like I said, because not everything is super objective in dollar terms. Here's another study that just looks strictly at the charity care portion of what nonprofit versus for-profits and governments give. And unsurprisingly, you can see government has more charity care for $100, and for-profit was actually kind of in the middle. But the other caveat to this is that within nonprofits and for-profits, you can still have a tremendous amount of variability about how those hospitals act. The only point that I have to make is it's hard to decide just based on a tax status exactly, you know, what their business incentives are or how well their mission or what they say is in line with what the actually do. So that's just sort of a general framework for buckets of how you can think about different groups. And it's really imperfect because groups can have features of multiple. So for example, I used to work for US Acute Care Solutions. It is technically physician owned, but does that mean that it's strictly democratic? No, because there are like, I don't know how many employees, they probably have like 3 or, you know, like 1,000 or something clinicians at this point. So you can't put everything up to a vote. Sometimes they do put things up to a vote, but there's still a smaller group of people deciding which things go to a vote and which things we're just going to kind of make an executive decision about. And then you have to think about, let's say you have an independent group that staffs 5 hospitals, but you needed to raise some money so that you could expand. And so you took out, you know, you gave up 20% of your practice to a private equity company so that you could grow your practice. You're still 80% physician owned. So that's kind of like a combination of being an independent group or a contract group, but also having a little bit of like a corporate investment component to it. And then the other thing I just want to emphasize is like businesses that have the same ownership type. There's just like so much heterogeneity within one specific type. And even within the same group, if you imagine a large group that's staffing 150 EDs, there's still going to be a ton of variability at the different ED types. Like you might, let's say you work for like an evil private equity CMG, but you work at a site that has a very stable group of docs that has been there for 30 years, has a great relationship with the hospital and can really advocate for you. Your day-to-day and your shift life might actually be really good, despite the fact that you might not like who your corporate was over. Okay, so since that kind of framework is imperfect, I want to just give you some factors. So the whole point of knowing who owns you is really supposed to be a proxy for what I would argue you actually care about. And so I think these are the actual dimensions that you care about. One is who owns your practice. Some people have an ideology about like who should own healthcare in medicine. Unfortunately, we live in a capitalist society where private investors are allowed in healthcare, and there are a lot of forces that are driving that. And it's totally fine to have like an ethical opinion about that, but that is the world that we live in. If you want to profit share, if you want to have profit sharing in your practice, then you need to be an owner in that practice. As a hospital employee, you don't own anything in the hospital, so all of the profits go to the hospital or your hospital group, and they decide how to disperse that. If you want to have direct understanding of where all the money is going and take share in those profits, then you want to be in a group where you're a partner. However, that also means on the flip side that when with the pandemic and you're not making money, you have to take a hit personally in order to pay the rest of your employees. Some people really care about transparency. Are your books open? Can you see everything that was billed under your name and how much the practice collected and how much they gave back to you and how much administrative oversight is taken? Then there's the aspect of liability, whether that's legal or ethical in terms of what happens around the practice. In a hospital model, it doesn't really affect me that much if my colleague sitting next to me is underperforming and not meeting their RVU targets. But if I work in an independent group, if my colleague is performing poorly, that's going to directly affect the viability of my practice and how much money is needed. And then there's just the general responsibility of managing the entire practice and how much control you want over the different positions. So this is just a rough cut, like my opinion only, of sort of the charting in very general terms along these practice dimensions. So on one end of the spectrum, you could be a sole proprietor and have complete ownership of your practice. The next level down, from the individual physician's perspective, is you could be in a democratic or independent group. In the middle is a contract management group. Next would be like a corporate model. And then in a hospital employed model, you have 0%. Profit sharing kind of varies, but let's say you get more profit sharing if you're in a partnership track. And then as a sole proprietor, your profit sharing is kind of up to you. So you can either take all of it or disperse it however you want. And then sort of down the line, you get less profit sharing. Transparency as a sole proprietor, it's your business. Everything is open to you. In a democratic or independent group, theoretically, everything is open to you. But again, that's the kind of question you have to ask when you're interviewing for the job because it's not necessarily a given. And then the other types of models generally have less transparency. Although in some ways, if you worked for like a public company, for example, they might have a legal obligation or regulatory obligation to share some of their financials. And then there's liability, which I won't go through, responsibility, and control. The ultimate point I want to make, though, is for you to remember that there's a lot that goes behind the scenes in opening and running an emergency department. And it's totally valid for you to want to care about how much you own and what kind of input you have in your practice. But there's just a trade-off between how much ownership and control you want and the responsibility and liability that you take upon. I know we're closing up in a couple minutes, so I'll just put a plug for this job website called Ivy Clinicians. They were the first group to really be able to demystify who staffs every single emergency department in the country, which is a tremendous feat of data. And so if you go on their website, they have like a job report and you can see like who some of the largest employers are. And they kind of break it down by different ownership types like private equity, clinician partnership, which can range from a regional all the way to national, government and health system. I'm going to skip this since we're out of time, but one thing I just want to put on your radar when you're looking for a job is something else that can affect your work environment and your benefits and salary is whether you're an employee or an independent contractor. The short version is that as an independent contractor, you might make more cash and you have a higher IRS limit of how much you can contribute to your retirement, but then you're responsible for obtaining your own benefits and malpractice. So that's going to come out of your tax salary. All right. So I think what we really all want to know is like ownership correlated with job satisfaction. I think probably, but unfortunately, this has been really hard to study because up until recently, it really hasn't been transparent who's staffing what departments. So it's just really hard to disentangle and study any kind of effect. There was a study that came out in July that was able to look at like the private equity market penetration using Medicare claims data in emergency medicine and anesthesia over the last 10 years. So that was a pretty groundbreaking study, and hopefully that person, Warren Adler, is going to continue to do more studies and actually start connecting the ownership with different outcomes that we might care about. So these are my references, and I'll just close with a couple of random things. One, just shout out to the best class of Kings County ever. And finally, this is my last year on the EMRA board, and therefore someone else from Kings County can run now. So if anybody is interested, please reach out to me. You have to declare by August 26th. It was the best professional decision I made in my life, other than going to Kings County, I guess. And yeah, so my ultimate conclusion is just try to understand what you care about. Know that business model affects some things, but it's not necessarily the end all be all, because ultimately what you guys are going to care about is geography and your compensation and, you know, maybe some other stuff, but that geography and compensation is going to drive a ton of your decisions as it is. So instead of just blanket looking at business model, try to understand like what is it about the business model, like the business model is a proxy for some of the other things that you care about. And then finally, just remember, most people don't stay in their first job for more than 1 to 2 years. So you have a lot of flexibility to try different things, and your first job is not going to be your last. All right. I'll take any questions if we have time, but other than that, if hi.
So I actually wanted to confuse the hospital and the employees the contract between practices in the what actually is for individuals so that I could now what happens to
yeah, so that's a good question. That's actually another reason why you might care about the employer, because we've seen Envision and APP that staff many sites that there's something about their background business practices that is like financially unstable. And it's not to say that every private equity practice is subject to bankruptcy or closing, but it is definitely true that private equity has different incentives. You know, like all practices have a profit incentive, but private equity probably has like a shorter term incentive to generate profit that can incentivize riskier practices or taking on more debt, which is probably what Envision did. And so, you know, that can create a lot of instability for you potentially. Although to be fair, like if you work at a large health system that looks stable, you don't actually know if it's stable, and this is like really opens up the book. So how does that affect the average ED doc? I think A, it's really stressful, but B, at the same time, emergency medicine is kind of unique in that even if your corporate order changes, which happens a lot in EM, especially now, you're probably still going to have a job. It might be with like a different employer, and your contract terms might change in a more or less favorable way, but you'll probably still have a job. You know, like at APP, for example, that company literally went bankrupt, and some groups moved in within like 48 hours to take over their contract. What we're seeing so far is like a third of them are going to like physicians, like smaller physician groups, a third are going to like larger groups, and a third are going to systems so far. But the point is, like, those people are still going to work, they're still seeing patients. There's probably some instability in where they're getting their paycheck in the terms of their contract, but I think the short answer is uncertainty. Yeah. Oh, sure. Yeah, we could talk about that. No, so one of the things that these arrange. One of the parts of these like contract arrangements is that the staffing groups have an exclusive contract with that hospital. That's just like one of the terms of between the hospital and the staffing group. And then therefore in your contract will be with the staffing group and it will say that basically you have to work in the staffing group. Yeah. So that kind of brings up sort of an adjacent thing about like non-compete. Is that something you might look for in your contract? There are non-compete clauses are questionably enforceable, but usually if you work with like large groups, you can still work at other systems. They won't necessarily bar you from doing that. But like for example, where I work, I'm actually not allowed to like work on the side anywhere else other than Penn. I don't know if I'm allowed to say that, but there it is. So like that's another thing that you might care about is like, is your contract restricted to letting you work per diem at other places? Awesome.